Welcome to the Neurology Live Mind Moments podcast. Tune in to hear leaders in neurology sound off on topics that impact your clinical practice. I'm your host, Marco Meglio, editor with Neurology Live. In this episode, we sat down with Dr. Andy Berkowski, founder of Relax Health and vice chair of the American Academy of Sleep Medicine's Clinical Practice Guidelines Task Force, to discuss the recently published AASM Guidelines on the treatment of restless leg syndrome. Berkowski gives insight on the reasons behind the guidelines and the mounting of evidence research since their last update in 2012. In addition, he provides an overview of the greatest changes, as well as how the guidelines impact different ages, sexes, and subtypes of RLS. Furthermore, he touched on the different aspects of the guidelines that were difficult to draft and the level of confidence in treating this condition going forward. Let's dive in.
Well, with all guidelines, the hope is that there's ongoing research as time goes on. So for the American Academy of Sleep Medicine, the previous guidelines were published in 2012. So just from a kind of a 10-year timeline, it was time to update the guidelines. But in the case of restless leg syndrome, it was particularly important because if people actually compare the new ones from 2024 to the 2012, they almost look inversion. They're an inversion of each other, 180-degree turn of events. And that didn't happen overnight. That's been evolving even before 2012, but it's been evolving over the past 12 years. So in this particular case, it's not just a 10-year interval thing. It's, wow, the clinical practice has changed dramatically, or I should say, should change dramatically, in part based on these guidelines. And so it's extremely important because most other guidelines, you're not seeing a dramatic change from even in a 5 to 10 year interval, unless, new drugs or new treatments come out. But in our case, a lot of the drugs that weren't recommended very much or treatments weren't recommended are now strongly recommended. And some of the strongly recommended treatments from 2012 are recommended against. Very dramatic and very important to get the word out for these guidelines and to change clinical practice because it's going to lag behind the clinical practice of restless leg specialists per se.
Yeah, as you mentioned, usually these guidelines kind of come out every 5 or 6 years or so. So definitely a lot of changes over a 10-year period, to say the least. So talk a little bit about the guidelines, give a little bit of an overview of some of the new points to these guidelines, and just what should they key in on with these guidelines?
Right. So the guidelines are basically, it's a systematic review and meta-analysis. So in a lot of research circles, this is like the highest level of study where you're actually researching the research studies. You're putting all the best studies together and making one larger study out of them. And it's using a process called the grade method, which is used by a lot of organizations, but it's a very systematic approach to evaluating research. So basically our group covered, 40,000 articles on restless leg syndrome, and several dozen met the inclusion criteria for the analysis, which met that highest level of research threshold. And then it was analyzed together, and the task force was assembled of 7 specialists in this area of restless leg syndrome, mostly neurologists, but some from other fields. And we analyzed this data. This took 5 years. We met at least once a month, sometimes in person, a lot of times through Zoom, but we had assignments between each meeting. So this is a very long process. So it's the 2024 guidelines, but it started in 2019. The biggest thing to understand is that these are the guidelines based on generally the primary treatment of restless leg syndrome as well as periodic limb movement disorder. So this isn't for, 6th or 7th treatment option or very, very complex cases. This is generally should be applied to any clinician, whether it's a neurologist, a primary care doctor, a nurse practitioner in family medicine. Any of these people should be able to look at the guidelines, see a patient with the diagnosis of restless leg syndrome and provide a treatment based on the guidelines. So it's not a law, it's not a requirement. So the drugs that are recommended for don't have to be used. The drugs that are recommended against, people aren't banned from using them. So it's important to understand that point. And then the second point is that it's only based on published research. So if there's a drug that someone's using that's not in here, it's not because it doesn't work or it's a bad drug. It's just that there weren't basically randomized controlled trials of the drug. And we make that very clear as we can only comment on what has been published. We're not giving an expert opinion on what we think is the best drug or what we use in our clinical practice. So with that being set forward, the biggest change, this is the most important thing in the guidelines, is the dopaminergic agents are not recommended in the treatment of restless leg syndrome. This was a conditional recommendation, but we have basically gone from the point of, at least with the latest study in 2022, 60% of individuals with restless leg syndrome were being prescribed these drugs. And we do not recommend the drugs in most cases. Why is that? The phenomenon of augmentation, most of the audience should be familiar with this process, but due to changes in the dopaminergic system with long-term use of these drugs, it tends to make the condition worse, almost to the point that it's generally worse than it can naturally occur, the wild type version, so to speak. So you get a condition that is worse than when you first started on the drug. And guess what? It's not 100% reversible if you go off the drug. And even worse than that, it's very hard to get off the drug due to dependence of the central nervous system on the drug. So once you go down this pathway of dopamine medications, dopamine agonists and levodopa specifically, it's hard to get the patient back. You can't, it's not like it just doesn't work and we could just stop the drug. You've now made a newer condition that's iatrogenic. It's much worse than it was before they started the drug, and you can't get them off the drug either. So this is a very serious situation. And that's been the main difference between 2024 and 2012, is that the overwhelming evidence of this process occurring more and more as time goes on, because a lot of these drugs were FDA approved for restless leg syndrome in the early to mid 2000s. Now we've got 20 years of data to show that this process happens every year and it just accumulates over time. So that's the biggest change in the guidelines. I would say the second biggest one is the promotion of iron, the importance of iron. And in the guidelines, outside of the recommended treatments, we have what's called a good practice statement. And the good practice statement is that one of the key points is that iron is so important to the pathophysiology of this condition, the low brain iron levels, poor iron metabolism in the central nervous system. It's so fundamental that individuals with restless leg syndrome should be tested regularly for their serum iron levels. So ferritin and iron and total iron binding capacity, which is also called the iron saturation, transferrin saturation. These should be done in the morning while fasting overnight. And in this situation that a lot of the individuals who have had restless legs for a long time, they may go without any knowledge of their iron levels. They may be persistently iron deficient and no one knows about it. And the second point, other than the fact that they should be monitored for iron, is that the iron levels for those with restless leg syndrome are not the reference ranges that you see in the lab, which are based on the population of the people, percentile-based population. There is a clear threshold. The threshold, however, it's not based on studies of, what threshold relates to what change in the condition. So there's been no testing of these gradations of what iron levels are the cutoffs. So we generally say that individuals with restless leg syndrome should have a ferritin level above 100 and a transferrin saturation above 20%. And so either of those is low. They may benefit from either oral iron or intravenous iron, and those would be the two main treatments. So with that in mind, the new treatment that's strongly recommended is ferric carboxymaltose. It's one of the higher strength, high iron binding forms of iron. It's a slow release form of iron. So it's very well, it binds very well to H-ferritin, and H-ferritin we think penetrates the central nervous system and may be highly involved in restless leg syndrome. So ferric carboxymaltose has been the most well-studied in restless leg syndrome, so it obtained a strong recommendation. But ones that we use very, very commonly, low molecular weight iron dextran and ferromoxetol also received conditional recommendations for, and only because there's just less research on those drugs, but it's thought that these drugs, these big three drugs, and there's another one called baric-darisomaltose, which is even newer but hasn't really been studied in this condition. So those four drugs really are going to be the backbone of treatment, particularly in those who have low normal iron levels for restless leg syndrome. The other major group of strongly recommended treatments are the alpha-2 delta ligands. Those we all commonly use for neuropathic pain now, maybe in the past for epilepsy, but mostly neuropathic pain. These include gabapentin, enacarbil, and pregabalin. All three of these have strong benefits in terms of randomized clinical trial results, and they outweigh any of the adverse effects with these drug classes in most cases. And as I forgot to mention at the beginning, the great criteria ultimately, when you're looking at a treatment, you're looking at the difference between benefit and risk. And so it's really the benefit of the drug versus the risk. So are the alpha-2 delta ligands or iron infusion the most powerful treatment? Maybe not, but they're the ones that have the most separation between risk and benefit. And that's why they have obtained the strongest level of recommendation based on the randomized clinical trials, mostly with these treatments.
We're going to take a quick break from our conversation with Dr. Berkowski to keep you up to date on the latest developments in neurology. Welcome to the Neurology News Minute. Here's what you may have missed since our last episode. First, on November 18th, Neurology announced that a trial participant in its phase 1 study had experienced an emerging treatment-related serious adverse event with high doses of NGN-404 and AAV gene therapy for Rett syndrome. The participant developed systemic hyperinflammatory syndrome, was considered in critical condition, and the situation is ongoing, according to the company. Days later, on November 20th, Sage Therapeutics announced that it will discontinue its development of SAGE-718 and is closing the ongoing Phase 3 Purview study based on new disappointing findings. All told, the therapy did not meet its primary endpoint in the Phase 2 Dimension study of patients with Huntington disease with cognitive impairment. Lastly, on November 25th, Cassava Sciences announced top-line data from its Phase 3 Rethink OWL study with results showing that investigational sumifalam did not meet each of its pre-specified co-primary, secondary, and exploratory endpoints in patients with mild to moderate Alzheimer's disease. As a result, the company decided to discontinue its second Phase 3 study of the drug called Refocus OWLS. For more information about these stories, head to neurologylive.com, or you can check out the corresponding link in the show notes. And now, back to our conversation with Dr. Berkowski. Oh, it's very, very all-encompassing. Obviously, a lot of major changes. And I know we've talked to Dr. Winkleman before about some of the dopamine agonists and some of the issues that we've seen in terms of the augmentation and things of that sort. So obviously, very, very important to get those things in and change the course a little bit of what we're doing and ensure that patients aren't harming themselves further. Dr. Berkowski, I'm also curious, were there any major notes in these guidelines in terms of differences for patients or how we treat them based on age, sex, or even subtype of RLS?
Yes. So in our guidelines, we did attempt to look at the literature for other categories, including adults with special conditions and then children, as well as children with special conditions. Unfortunately, there's really only strong research for adults with end-stage renal disease, and there were quite a lot of studies of this in terms of that special population, and we did make recommendations that includes gabapentin, a form of IV iron infusion, iron sucrose, which we did not recommend in adults, but there was evidence for it in end-stage renal disease, and as well as vitamin C, good old vitamin C. So that was one category. And then, of course, the dopaminergic agents were recommended against, even in the population of end-stage renal disease. Unfortunately, a lot of the categories we would like to have data, particularly things like pregnancy or those with other neurologic diseases, there's just no research right now showing what treatments should be used. And we're looking at Alzheimer's disease, Parkinson's disease, where many individuals have to be on levodopa as part of their treatment, which actually might be making their restless legs worse at the same time. What do you do with individuals with Parkinson's disease? We would love to answer these questions. We don't have those answers. In children, iron is really going to be the key. Again, the research only supported ferrous sulfate as an oral iron supplementation. We couldn't even make a comment on IV iron, which is suspected to be effective, but there were no pre-post studies that used really strong validated measures, so we couldn't comment on it. So there needs to be research in these areas. And then a last area would be not really restless leg syndrome, but it's periodic limb movement disorder, which is an entire separate entity. Somehow it got smushed together with restless leg syndrome. And periodic limb movement disorder we're still at the stage where we don't really know what it is. We need to come up with ways of better figuring out the biology, the pathophysiology of it, how to diagnose it. It's probably exceedingly rare. If we can come up with a criteria, most of the treatments for periodic limb movement disorder did not show any type of benefit to any of the major categories and domains we looked at. So we basically recommend against a couple of treatments, and we don't have any treatments we do recommend. Our recommendation for periodic limb movement disorder is further investigation into how to diagnose it and what the nature of it is before we can decide to treat it.
Well, it's very interesting hearing some of the small nuances between some of the pediatric or adolescent populations and some of the adult populations. You also kind of dove into it a little bit there, Dr. Berkowski, but were there any aspects when you guys were drafting up these guidelines that seemed to stump you guys, or maybe you just didn't have the answers for, or things of that sorts that maybe just didn't make it into these guidelines per se?
Well, yeah. So that's some of it. One of the difficulties we had was in some of these treatments is to how to classify them and whether we could make a comment on them. So one of the ones I haven't mentioned yet are what we call oxycodone extended release and other opioids. We kind of debated back and forth, and then there was some guidance back and forth from the board and as well as those who are experts in this grade process. But we concluded that the clinical research was on oxycodone for the treatment of restless leg syndrome, but we know that it is really a strong class effect of the medication of the opioid class. There is great scientific or basic science research showing that there may be deficiencies in the endogenous opioid system of the brain as part of the contribution to restless leg syndrome. And that could be why opioids at very low doses are so powerful in their effect on restless leg syndrome. And in fact, often the majority of people with severe augmentation need opioids to get off dopamine agonist medications. That's the only thing, you got to fight fire with fire. And those are the two powerful treatments. So we were able to throw in the other opioids because people are going to ask, oxycodone extended release is not the most commonly used opioid. Probably methadone, maybe buprenorphine now is becoming more popular. Why aren't we recommending on those? Well, there aren't pre-post studies yet that have been published that we could have said, hey, we could recommend that specific drug. But we were there's so much strong evidence that it's a class effect, we were able to put that in there. But that did kind of stump us to some extent. And then there were other decisions that you might not see in the guidelines is, well, where do we draw the threshold between, well, is it beneficial with very little harm, or do we just not make any comment on that? And some people will be surprised that there are some drugs it's just not mentioned. We don't make a comment. Iron sucrose in adults is one. It's probably better than nothing, but actually the studies didn't show a benefit to IV iron sucrose in adults. It did in end-stage renal disease, but adults without end-stage renal disease, it did not show benefit. We do have scientific reasons why it's not as effective as the other types of iron infusion. So we didn't recommend it. We didn't recommend against it. So those are some of the decisions. There are other types of treatments that met the threshold that we did put in there, such as dipyridamole, which is a relatively new, it's an old drug, but a newer treatment for restless leg syndrome. But there was a very good randomized clinical trial of that drug, and the downsides of the drug are much less, even if we don't have long-term studies of the efficacy of the drug. So that's sort of where the difficulty in decision making was made for this task force.
Yeah, I know the conversations of opioids are obviously a very, very touchy conversation to say the least. And I know, we've kind of heard the same thing from a lot of other specialists with RLS that, in low doses, when used appropriately, when used with a clinician who knows what they're doing, who has experience, that obviously these can be effective treatments when used in the right forms and the right ways, and things to definitely consider going forward. Dr. Berkowski, great, great insight from you. Last question for you. With these new updated guidelines, how confident do we feel in treating RLS these days? Talk a little bit about the future of treating RLS and just what these can do and what they can spring for the community.
So one of the points I'd like to make is that even before you're looking at these treatments and the guidelines, we should all be looking at the good practice statement about ways of preventing the condition and behavioral and habit modification for dealing with symptoms of restless leg syndrome. We have the opportunity to create a new generation of individuals with restless leg syndrome who are not exposed to dopamine medications, which we're dealing with. So we're actually dealing with a more severe set of patients than we did maybe 25 years ago before these drugs were starting to be used. And a lot of these modifications to behavior prevention of the condition can be effective in those who have de novo restless leg syndrome. Things like good sleep schedule, good sleep hygiene, getting rid of vices, your caffeine, alcohol, nicotine that trigger restless legs, deprescribing some of the prescription drugs that worsen restless leg syndrome. So the future is bright because we're going to get a new generation that are not developing worsened conditions through augmentation from dopaminergic agents. And we'll be able to treat them with things like iron, which is more getting at the root. We're not treating the symptoms, we're getting at the root of the condition now. We're preventing the condition, we're getting at the basic pathophysiology. And then that will allow us to use these drugs less and less actually over time, because you'll have reduced cases of severe restless leg syndrome. So I think the future is bright. And then of course, the research moving forward, we do need more research and new treatments. We need to know how to address the people who are on the 60% who are on dopaminergic agents right now. What do we do with them? So there's a lot of unanswered questions, but I think we're basically starting over. And if we start over using these guidelines as our to guide us both in the field of neurology, primary care, then I think you're going to have a happier population than you see right now, but maybe 15 to 20 years from now, when the new generation of people are treated with the right system in place.
Thanks for listening to this episode of the Neurology Live Mind Moments podcast. To support the show, be sure to rate, review, and subscribe wherever you listen to podcasts. And as always, for more neurology news and expert-driven content, visit neurologylive.com.